Okay, so bacterial keratitis. Symptoms: red eye, moderate to severe ocular pain, photophobia, decreased vision, discharge, acute contact lens intolerance. Signs: critical, there's a focal white opacity, which is infiltrate in the corneal stroma. An ulcer exists if there is also a stromal loss with an overlying epithelial defect that stains with fluorescein. Etiology: bacterial organism are the most common cause of infectious keratitis. In general, corneal infections are assumed to be bacterial until proven otherwise by laboratory studies or until a therapeutic trial of topical antibiotic is unsuccessful. Staphylococcal ulcer typically have a well-defined gray-white stromal infiltrate that may enlarge to form a dense stromal abscess. Staphylococcal infiltrates may be either very purulent or crystalline. Severe anterior chamber reaction and hypopian formations are common in the former, and the latter tends to occur in patients on chronic topical steroids. Pseudomonas typically presents as a rapidly progressive, suppurative, necrotic infiltrate associated with a hypopian and a macropollen discharge in the setting of soft contact lens use. Workup. History. The contact lens wear and care regime should always be discussed. Sleeping in contact lens, this generally increases the risk of bacterial keratitis and should be strongly discouraged. Daily or extended wear lenses, conventional, frequent placement or single use. Disinfecting solution use, recent change in routine. Swimming or hot tub use with lenses, trauma or corneal foreign body. Corneal surgery, history of refractive surgery. Eye care before visit, previous corneal disease, systemic illness. 2. Slit lamp examination, stain with fluorescein to determine if there is epithelial loss overlaying the infiltrate. Document the size, depth, and locations of the corneal infiltrate and epithelial defect. Assess the anterior chamber reactions and look for a hypopian and measure the IOP by tonal pen. Corneal scraping for smear and culture if appropriate. In contact lens wearer suspected of having an infectious ulcer, the contact lens and cases are cultured if possible. Explain to the patient that the culture contact lens will be discarded. Treatment. Ulcer and infiltrate are initially treated as bacteria unless there is a high index of suspicious of another form of infections. Initially, therapy needs to be broad spectrum, cycloplegic drop for comfort and to prevent synechial formations. Use atropine 1% TID when a hypopian is present. Topical antibiotic according to the following algorithm. Low risk of visual loss, small, non-staining peripheral infiltrate with at most minimal anterior chamber reaction and no discharge. Non-contact lens wearer, broad spectrum topical antibiotic for quinolone. Contact lens wearer for quinolone. Drops Q12H. Can add tobramycin or ciprofloxacin ointment QHS. If using ointments more than Q1H, use ciprofloxacin ointment. Borderline risk of vision loss, medium size, 1 to 1.5 mm diameter. Peripheral infiltrate or any smaller infiltrate with an associated epithelial defect, mild anterior chamber reactions or moderate discharge. Use fluoroquinolones Q1H around the clock. Consider starting with a loading dose of Q5 minutes for 5 doses and then Q 30 minutes until midnight, then Q1H. Vision threatening. A current practice at Will's Eyes is to start fortified antibiotic for most ulcers larger than 1 to 2 millimeters in the visual axis or unresponsive to initial treatment. Fortified tropomycin or gentamicin Q1H alternating with fortified cefazolin. This means that the patient will be placing a drop in the eye every 1/2 hour around the clock.